Right, I'm gonna go ahead and call to order the special meeting for the Seneca Healthcare District Board. Let's do our roll call. Shelley's here, Sherry's here, Ken's here, and Rich, I think you're on the line.
I'm here, yes.
All right, perfect. Let's go ahead and rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. That brings us to item number 2, additions, modifications, or deletions from the agenda. I have none. Board members, staff, anything? Okay. Then number 3, I will accept a motion to approve the agenda.
Move approval.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Rich?
Aye.
Ken?
Aye.
Sherry?
Aye.
Shelley?
Aye.
And I'll vote aye. That brings us to our public comment period. We did have one public comment or question submitted to us through our website asking how many beds will the new Seneca Hospital in Chester have? And so I just want to make sure we reiterated that it will have 8 beds for the hospital, 4 for the ED, and 26 skilled. Any other public comment, questions, anybody? No? Okay, then that moves us to our closed session where we will be doing litigation, anticipated litigation, Congress legal counsel, significant exposure pursuant to paragraph 2, 3, or 3 of subdivision D of section 54956.91 case. Trade secrets, health and safety code 32106, reports involving trade secrets, and public employee performance evaluation pursuant to government code 54957, public employee performance evaluation, chief executive officer. And that brings us to our closed session. All right, our closed session is closed from our special meeting and adjourned, I guess. And
No,
then,
we will be carrying it over until 5 o'clock.
oh, I have those same items on the agenda for our regular meeting too.
Okay.
Yeah. Okay, all right, so let's go to order the regular meeting of the Seneca Healthcare District Board. We have Shelley's here, Sherry's here, Ken is here, I'm here, Rich is on the phone still.
Yes.
Thank you. All right, let's rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, that brings us to item number 2, additions, modifications, or deletions from the agenda.
Before we
I
go
have
there,
one.
I'm getting
Yeah.
a text saying that,
Oh.
message is saying it's still waiting for host. People
Forget
trying
it.
to
Thank
sign
you.
in.
Did we get everyone in? Got everyone in? Okay, perfect. Thank you. Thank you, Rich.
Okay,
Okay. That moves us to item number 3, approval of the agenda. Do I have a motion to approve the agenda?
A motion to approve it.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Ken?
Aye.
Shelley? Sherry?
Aye.
Rich?
aye.
And I'll vote aye. All right, that brings us to item number 4, public comments. Any public comment to be made, either online or in the room?
No.
Anyone online? Okay, moving right along, then item number 5, approval of the March 27th, 2025 regular board meeting minutes. Board had a chance to review, any comments, edits, motion to approve?
I'll move to approve.
Thank you. Do I have a second? Thank you. All in favor, Shelley? Sorry, Shelley?
Aye.
Sherry? Ken?
Aye.
Rich?
Aye.
And I'll vote aye. I think I should buy both your
It
names
was a
together.
blend,
I did. Because you're sitting by yours. All right, that brings us to our staff reports. Sean, you're up. You want to give us some highlights?
Yeah, let me just give you some highlights. I put a huge tracking legislation page here.
Yeah.
Because there is a bunch of
A lot of
legislation
stuff.
coming down. The top ones that were more in the blue, which is down to SB 530. is kind of encouraging. This is actually the legislature chasing the insurance companies for trying to get them to comply a little bit and be a little bit more forthcoming as it relates to referrals and denials, and they have to publish their denials and why, they have lesser time to approve. So it
I
seems
saw
like
that, that looked really
finally,
interesting,
yeah, finally, it sounds like the
That's impressive.
legislators are starting to put the thumb screws on the insurance companies to start being more responsive to healthcare, to the providers.
Mhm.
So I'm actually pleased with those top ones.
The perinatal one though.
Yeah,
that
well,
one-
Yeah, I saw it.
yeah, this I think is just, the perinatal one is more the basic service, general acute care hospitals to include perinatal basic. This one I don't really understand. You can't force by law, in my understanding, you cannot force a provider, government or otherwise, into providing a service that they can't provide with quality. Or that they can't support without, I mean, they can do anything they want. But I think this is gonna be more around the perspective of, requiring geographically certain ones to be able to do it. Right now, Susanville provides all that care. So I think it's gonna be, they're gonna take a look at the big swath of where it's gone, and then they have the ability to assign these services to somebody so that it's not completely void.
Interesting.
I tried to read up on this, it's very vague about what they're trying to accomplish, but I think this is trying to tackle the issue that OBGYN is kind of drying up, and so I think they're trying to take it on from a legislative perspective. We'll see where this goes.
Perspective.
Well, definitely from a Medi-Cal, yeah. The other one is, it just drives me absolutely bonkers, is, SB 596, it's sponsored by SEIU. This would require that
Yeah.
the on-call list is to be at least 10% of the hospital's registered nurses
Oh my gosh.
at
Yeah,
all times, so
crazy.
you have to have 10% of your nursing staff on call all the time. And this is a union push, it's ridiculous, but it's being sponsored. The problem is it's being sponsored by the chair of the Senate Health Committee. So again, the legislature appears to be in the union's pockets. This is a ridiculous one. I don't even know, I didn't even calculate the cost of this, Brady, of 10% of our nursing staff being on call. When you don't really need them on call.
Yeah.
Again, just trying to rub us. The other one that a lot
Well,
of you.
and my question is that 10% of your staff or is that 10% of your staffing? So, you have X number of nurses on shift at a time, is it a percent of that?
10% of it, at least 10% of the hospital's registered nursing staff.
Yeah, which makes no sense
Tells
to
me
me. Like
registered
everybody.
nurses.
which,
Yeah.
which makes no
Everybody.
sense.
Well, you wouldn't have clinic nurses covering the ER or acute.
Yeah, it,
So
again,
it would
the
be the
ambiguity
ER and
is
acute,
crazy.
I would imagine.
Of the hospital's registered nursing staff, so it would be clinic, but
Yeah.
still, it makes that just ridiculous. It's just a way for the union to have a win where people are getting paid and,
Well,
for doing nothing.
Or it'll make it so that everyone has to go work for a staffing company.
Mm.
Because then
Yeah.
you're not gonna your staff.
Yeah,
Ooh.
That's the other, that's the other way.
Yeah, that would be troublesome.
Mhm.
Remind me to start a staffing company. Is that insider trading?
We
It's all
have that
public- it's all
recorded,
public
right?
information.
Yeah.
Is this on? Sorry. Ooh. Okay, and the other one that's a little bit bothersome for me is, the SB 632. So this bill that's been attempted, and they just keep bringing it back, would create presumptions that many injuries that develop or manifest in a hospital employee who provides direct patient care in an acute care hospital arose out of and in the course of employment. Ridiculous.
Yeah.
Absolutely ridiculous. This has been shot down, I believe, twice.
It's like saying it's not healthy to work in a healthcare.
Well, they're saying
facility.
that you assume that the injury was brought on by your work. And it could be brought on by being a bull rider, but it doesn't matter. It's gonna be the hospital's fault. And
Similar
ultimately-
to deputies.
Okay, so this is troublesome. I think it'll be defeated. I think there's some sanity that's getting built into some, well, maybe, we'll see. So lots of legislation. I'm gonna be tracking legislation like crazy, let alone the whole Medicaid, Medi-Cal issue in Washington. There's still really no concrete evidence of the sky is falling that's happening. There's a lot of sky is falling things going on still around Doge and the cuts to Medicaid. Medi-Cal. I think that the biggest concern I have with that is that while Medicaid, this is a lever on the agenda of the current administration. That's my concern, especially for California, because we are sanctuary. And the current administration doesn't like any of that, so what we do is they cut the Medicaid funding to certain states, which dries up the Medi-Cal, doesn't support the Medi-Cal, which forces them to drop coverage for perhaps, and I'm just reading the tea leaves in Washington, which perhaps makes them drop coverage for people that are not documented, kind of forcing them into that non-sanctuary thing and not giving away things. The problem is that, and it's kind of two sides, no matter where you think about where you stand on this, the people that are gonna get hurt are the providers. Because we still provide, and then we're gonna have a lot of people that are showing up in our emergency room with Tala
Yeah.
with bad debt, because they have no, so this is not a good, in my opinion, doing the cuts just to cut because is a really bad idea, because you're not looking all the way downstream, and the downstream is us. So there's a lot of concerns here, with it, and I'm hoping there's some sanity on the hill.
And some clarity.
Some clarity, I'm sure we'll get clarity here soon, right?
We're more confident than me.
Well, I'm, once again, I don't adhere personally to the sky is falling. But I think that anything Medicare, Medicaid, or Social Security is the kiss of death for any politician, any administration in history. They do that, those are entitlements. And you don't necessarily get to decide who the entitlements go to, I think.
Yeah.
But there's a push. It's a political lever at this point. So really interesting times for the providers. To page 2, if you haven't heard of OCA, you need to hear of OCA. So OCA is the Office of Healthcare Affordability. They are really taking a look at spend, how care is delivered. They a couple things. They're looking at consolidation. When, you know, the U.S. Attorney General used to look at consolidation. So there's a lot of consolidation in healthcare where the big organizations are swallowing up a lot of things. What it does is it removes the competition. They raise the rates. They become very, very expensive. So they're taking a look at cost overall for delivery, and basing it on quality metrics. So they're looking at, okay, you're super expensive, but your quality numbers are right here. Why are you so expensive? In fact, I think they came out with 5 or 10 hospitals that they've already went, you guys are super expensive. So you're on the radar. And it's not the big ones necessarily. It's an interesting little mix of,
Are they looking at healthcare plans also?
no,
Like
just
insurers?
delivery provider.
Because that's where a big amount of the expense comes.
Yeah,
Is
well, the
all
cost
that
of,
overhead.
the cost of care in the facilities is what they're looking at. This is affordability. There is some efforts on the insurance side, but they're looking at this. So, you know, their big thing is to slow underlying spending growth. You know, because it's constantly, they want to get us to 3%, which is basically the cost of COLA, cost of living. They'd like to see spending not exceed 3% year over year. Promote high value performance. Now, this is not a new high value systems performance. This is not a new idea. So this was the whole idea around quality beats quantity. We've been dealing with this for how long, right? But now they want to measure it and they want to put it into their rating. So if your quality is really high and your price is high, I think you get a pass, a little bit of a pass. But if your price is high and your quality metrics are low, no pass. You're gonna be on their radar. So I think that they're trying to make sense of that. And then the other one is access to market consolidation, which I just talked about. They're taking the place of the Attorney General.
Did Medicare restart the focus audits? Because I'm wondering if this is gonna be like an extrapolation of those focus audits.
It could be. I think what's
That's
happened is
cost and
they're taking over, especially in the city hall. All of this work that used to be done by OIG, Medicare. I think that OCA is the new agency, so we can employ a whole bunch of new people to do this work, which
Until
hasn't been
you
getting
spend
done
less
for a
money,
while.
so we can.
Yeah.
But I think also, maybe OCA was in preparation for cuts in Medicare and CMS,
Yeah,
where they can't do the audits now. State of California goes, hold on here, we got OCA
yeah.
to do it now. So, a lot of attention,
Outcomes, but cost.
yeah, a lot of attention on this.
What's their authority for enforcement?
That's what I was
Oh,
wondering.
it's absolute. They have the Attorney General on their side.
So say they
Are they
came to
under
a
the
facility and costs are really high
Uh-huh.
and the metrics are really low on quality.
Yeah,
And the facility says to them, hey, too bad, this is what we have to do to stay open. Then what's their authority? Can they step in and close them down or
they
Well,
will,
they'll do an audit.
they'll have
Audit's
alternative
fine,
payment, they'll put
if
them
you
on.
fail the audit?
Corrective action plan is what
So,
you gotta
so
do.
they're calling it APMs, alternative payment methodologies, alternative payments, so they could change the way that they get reimbursed.
That's
So
kind of
it's
what,
not, so the enforcement bureau to me is always at the purse. It's
that's
always
what I
at the purse
figured too,
strings.
is that they must have financial authority over.
But there should be a build up to that for us to be able to respond and.
I think there is, but if you can't
There's
respond,
corrective action
Shelley, I
plan.
think that they'll put you, the APMs, the alternative payment methods will be the controlling factor, the tightening of the belt. They'll basically say that you can no longer do DRGs, you can no longer do cost-based, you know,
Right.
you're gonna do this, and this is how you get paid. And believe me, every administrator in that department, in that hospital get in line,
Yeah.
right?
Sure.
They'll flow right in line, so it's all about the purse strings. You know, control that, so it's gonna be interesting, we're really watching OCA and what they're doing. And their initial,
Sounds like they're gonna be really watching us too.
yeah, yeah, I think we'll probably be okay, because there's some people that are pretty egregious out there, but we'll see what happens. How it grows. Any questions on OCA? Lots of fun stuff, regulation. So much fun.
Government.
Is it time for us to review our charge master?
What's
Is it
that?
time for us to review our charge master?
We review it every year, so, and make sure that we're not crazy people. Spring, summer focal points, we have been, this is a recent add to the focal point. Brady and I are taking on the radiology group, has come to us and, how do you wanna say it, just, are leveraging us, with a huge payment structure. So it's just, so we have to deal with the radiology professional services. We're looking at alternatives and looking at just the entire ecosystem around radiology. No one's graduating radiologists anymore. They don't want to go into the hospital. They don't want to work past 5 o'clock in the evening. So they're getting crushed by the lack of availability of doctors, and they're crushing us because of that. And it's in typical fashion, market drivers. And we usually get this about every 2-3 years, where they're in the driver's seat for a while. So radiology sciences, that's one. Orthopedic services contract is up. We're looking at that. I forgot to put one in here. We were essentially dropped by our pathology group. There was a retirement. So our lab medical director and our pathology and infectious control or infectious disease doctor is retiring, and so the company that she worked for basically sent us a termination notice. But we are working on that as well, so administration is quite busy just trying to manage.
Did you get 60 days? Were you given 60 days?
I can't remember, Judy and Judy's handling this
Yeah, I
mostly,
think it was 90.
I think it was 90.
Okay.
but,
Whatever's in there.
so these are real focal points for us because they kind of came out and sideswiped us a little bit. Took us off our game a little bit, but those are focal points. Advancing development of our swimming program, that's always been an issue, that's always been something we're focused on, and I think that we're moving along on that pathway. Physician recruitment, you're gonna see some information from Shanna's department and in collaboration with Chelsea around physician recruitment, and this is more to replace Dr. Ware and really taking a different approach.
When she retires.
Instead of recruiters, you know, which have proven to be pretty much. IT systems changes, we've already talked about these, SharePoint, web packs. A lot of philanthropic efforts as we move into our giving season. Sort of the golf tournament is our kickoff, but there's a lot of good stuff. I don't know if you've received this, but this is our impact report. Did it go out?
So it went out to donors over a certain amount.
Yeah, so
We have more imprinted ones coming in that all the board members and everybody else will get.
this is really good work. This basically is a year in review. It's our impact report. It's excellent. Did a great job on that, Chelsea. Thank you. And then philanthropic efforts and then monitoring construction project, and that's gonna be an ongoing thing all the way through. Just trying to keep it on track, trying to knock down walls. Sounds bad. Trying to take
Please
out,
don't knock on
trying to
wood.
take out the berms where the berms come up. Just trying to assist our contractor getting back on schedule through the regulatory, and Don has done an excellent job of just trying to work through some of the stuff. We're through a lot of it. I think a lot of the red tape, regulation stuff, we're through. We have increment 3, which we really need, and then we're working through that. But after that, I think, it's just monitoring, it's just moving things along.
What's the, how's the BABA compliance
Oh,
issue
I
coming?
actually got a letter today from Heidi's office. They've submitted a letter into Secretary Lutnick. And I've asked them to also forward it to Secretary Rollins, who's at the USDA. Lutnick is
Commerce, yeah.
the Commerce Secretary. So they have forwarded a letter into the Secretary to work on a complete exemption for all critical access hospitals in the state of California. And I've got 1, 2, 3, 4, 5 other critical access hospitals that are in the midst of doing this, that have also submitted the similar request to their legislator in Washington. So I'm hoping that Kylie's letter now will catch fire and they'll all move forward with it. So no exemption yet. But did get a response. And they did write a letter. So let Washington steam, let Washington steams. Regional activities, we're working on a regional podiatrist.
You're still talking with them about
Yeah.
sharing?
Regional mobile MRI provider, so there's been a couple of hiccups with regulation around Heritage. Who's gonna be our interim contracted provider for MRI to stand up our services again. They're moving through all of the steps you have to get the sticker here, the sticker there, now CPH. I did not get an update from my meeting this afternoon on when they think that's going to be. But when they get their sticker, we're gonna have to make sure that CPH understands that we've changed to providers.
Yeah.
There's that, and then the purchased mobile MRI, in the next board meeting, you're going to see the agreement. The agreement between all 5 of us. We are on a meeting today and finalize that. And I will be putting forth the contract and the 90-day no penalty. It allows us to cancel the entire contract within 90 days of taking delivery without any penalty. And we wanted that in there as an insurance policy in case things.
In case it didn't work.
So the board will be getting that in the next packet. Please take a look at that. It's a good contract. And then we're gonna be looking for approval to probably act as the management agency and go through. Seneca will be the sort of lead on that one.
How soon are we thinking we'll be able to, once it gets all approved by everyone? How soon till it can spin up?
I'm sorry.
6 months delivery?
Oh, no, we don't want, well, we have Heritage for 24 months. So we are going to time it out where they're coming off contract and our MRI is being delivered.
Oh, okay.
So we have under contract for 24 months, which by the way, it's not from the day they start, it's the day they signed. So they're losing that time, they're running time. We will time the delivery of the new owned MRI with the termination of the 24-month contract.
Okay,
So
and,
they're not in a rush. It takes about 9 months though,
okay, and we pay for it upfront or on delivery?
on delivery.
On delivery. And we have an idea about how much?
And it's going to be, all 5 of us are putting in 400. I think that 200,000 on NTE is actually 1.72. Complete. With the coach and the MRI and all the.
And if we're taking the lead, then we're gonna be staffing it.
No.
No.
We'll be going out to an RFP for a logistics company to staff it and drive it.
Okay.
That'll be part of the O&M, the operations and maintenance side of it.
Will they be able to do pediatric
Yes,
MRI?
does everything.
Okay.
And it does breast MRI. We actually have a breast coil too, so it can do it all. It is it's state of the art. You won't find one better in the valley.
Great.
So other than 3T.
Righty.
Yeah, but we're not gonna do that. So those are the big focal points, excitement on the site, lots going on, and we'll probably talk about that in the critical access hospital update.
That's
Okay.
good.
Yeah.
Thank
Any
you, Sean.
questions?
Any other questions for Sean?
No, thank
Great.
you.
Good
Thank
stuff.
you. Okay, so let's see. Judy submitted her report. I understand she's out of
On
town.
vacation.
Amazing. So jealous. But she deserves it though. I didn't have any questions on hers. Did anyone else?
No.
Okay. Thank you. Then let's move on. Brady, it's your turn.
Okay, thank you. So, Judy and I, some of the stuff is really together in this report.
Mhm.
So, a couple of things, just pure, facility wise. So we did receive 2 quotes for automatic doors there, so we'll propose that into the budget. And then the brain of this HVAC system is the other thing that we're going to be proposing this winter. It was a little bit interesting. We're trying to get ahead of Steve's budget cycle, so we're setting up our department meetings and starting to talk internal, so we're prepared for that. And then, you'll notice, this is the time of year, spring cleaning, where we paint walls, you know, and get the grass and all that. So there's a lot of that going on from Linda's team. JJ's working with their team and walking through the clinics and see, you know, really touch up doors, walls, carpet cleaning is gonna happen this weekend, all of that kind of stuff before summer hits us. So, everybody's pretty busy at that. In this transition steering committee, you know, we've done several with surgery, several with lab. One of the things, as an example, Judy noted that in her report, when we go through the medical list, the equipment list, through these transition steering committee gurneys, as an example. In a perfect world, we'd have one gurney that did everything, so no matter where in the hospital, it was the same one and you wouldn't interchange it, but that's not necessarily how it works. And so we're gonna get a couple different vendors, pull out their types of gurneys, like an endo gurney versus PACU gurney versus an ER gurney, and get some demos out here to really hone in on the equipment list, where it just gives kind of a basic one. Which one do we really want for which department? Trying to keep in a perfect world or a fleet philosophy, so it's from parts and interchangeability and stuff like that.
How many in total?
Well, we haven't got the count yet, because the ER, if it's 5 beds, there'd be 5, PACU is 3.
Oh, we bought some, did we buy some?
Yeah, we bought,
Yeah.
we bought some beds, but
Mhm.
the gurney side of it. And then, like in an endo room, there is an endo gurney. So if you have to run a C-arm, it's radiolucent, so you can do that. So that's why we need to kind of
Demo
look at the
them.
holistically, demo them, see which ones. I mean, there is the base standard, you know, pneumatic type gurneys to the, you know, you use your finger and they
Right.
automatically drive around. We do have a demo that is one of those that's been here for a while, in the ER, and it's like the top tier one that does weights and all sorts of things. I don't know if we need all of that, maybe in some areas, like going out to the helicopter or stuff like that. But that's why we're really,
Is that the one with the espresso machine?
yeah.
Massage.
Yeah, so that's why we're getting into the fine details of all this stuff, but that's a good example of, we really have to put some thought
Can
to
you
it.
rent a fleet? Is it possible to rent?
You can get loaners.
Maintenance is covered by the.
Yeah, you can get
Company.
loaners, you can do stuff like that. I mean, I'm sure there's a lease option if you bought a fleet. But that would be a more of a Steve question, you know,
Yeah.
from a depreciation and stuff like that. But, so that's kind of what's coming on the horizon. And so our goal is to get all these transition steering committees done by the end of this year, so that everybody's familiar with their space, what's going where. It helps in the change management of things, where people get excited, they get to see their space. They start mentally going, okay, if I'm in that space, how is my work going to be? Versus this is how we've done it in the past, this is a whole new day over there. So those discussions help people lean forward into it. And there's a lot of excitement around it, because how, you know, in your careers, how
Yeah.
many times does this happen? Probably never. So it's very exciting. Other than that, Sean talked about all the construction projects, and we're really getting into the weeds of everything, so that's going on. And other than that, any questions for me?
Brady? Thank you, Brady. Appreciate it. Okay, let's see. I don't think Brian is here. Ethan, are you giving a report for Brian?
I wasn't prepared with one.
Okay.
If there's any questions for the IT team, I'd be happy to answer.
That's perfectly fine. Any questions for Ethan?
I can give a little, so
Yes.
we have transitioned, and you can jump in when I cue you. So we went from our service provider, which is a company called Apex, to a certain level of service, and we're about 30 days into the new service agreement, which was less. Brian and Ethan and team have brought on internal tools to do those functions. So the team is growing and getting the skill set with the tools that they need, which from a budget standpoint is a better budget position for the organization. And that was kind of the game plan on last budget cycle, that we looked at all of that. So everything is going as planned. Is it Windows 10? We're 11.
We're upgrading to 11, yes.
Yeah, we're halfway through.
About, yes.
Yeah, about halfway through on that. So the IT team has been very busy, and that's not just the odd things that occur, but that's in their plan, what they're trying to deliver for us. We did get the mobile cart. They got the mobile cart. You'll see it in the hallway there. Retested it, making sure. Then the staff up there have been testing it so we can pull. If we have too many people, we can pull somebody off to the side and register and get them back. So
So it's not called a cow, right?
we don't say that anymore. We say, hey, wow.
We say, wow.
It's a wow.
I remember.
I like this cow. I used the cow.
We have cows everywhere.
Yes, the wow is functioning well, and they've used it, and so we're ready for that. But kudos to Brian's team. Brian is taking off to this big Cerner meeting where we gave him a whole bunch of like questions that we were trying to, questions we were trying to get through email, and you don't really get a response. And so we have a whole list from Steve's team to everybody. He's gonna sit with them and go, what about this? What about that? So
Great.
they're doing
Yeah,
really
the
well.
user group meetings
Yeah.
are really
uh,
helpful.
Yeah, so he'll be back next Thursday, right? Ethan?
I believe that's right.
Yeah. New knowledge.
Excellent. Thank you for that update. Thank you, Ethan, for everything that you guys are doing too.
Of course. Awesome team.
All right, Jen, you're up. What comes next?
So it's gonna tag team with me.
Sounds good.
Okay, so quickly on my agenda, kind of the same story. Still recruitment efforts remain high for LVNs and CNAs. We did interview, or Sean and Judy interviewed a physical therapist. He has been offered the position. He is looking for an offer letter. So it looks like it's gonna be a go on that one. So that's exciting.
Wow.
This one from Oregon, is that?
Fingers crossed on.
Very exciting.
Yeah, so, next is we have two controller candidates. Both look great. The first one, we interviewed already, and then the next interview is on Monday. So,
That's great too. Got some good movement. Yeah, I like it.
Yeah.
Getting really good candidates.
so next we'll go over, what Chelsea and I and Brady has contributed to our physician recruitment strategy. Kind of goes from start to finish, walks us through the pathway when an opening does come up. So first step, assess our needs, create a job description. Next is source candidates. And then this is really kind of starts with Chelsea and the marketing strategy and budget. So, sorry, I was trying to pull up that sheet right now.
Yeah.
You wanna look at that? Sure.
Well,
That document,
you have to,
the recruitment one.
What?
there you go.
There, thank you.
Absolutely.
Perfect.
Yeah, so with the marketing strategy, so basically our initial plan would be to market similar to the way recruiters market. So using the digital marketing, the postcards, and we want to implement a letter. So we've actually gone through and picked out different platforms. We picked out some recruitment platforms as well.
But then we'll still use like the LinkedIn, a variety of platforms just to make sure we are kind of hitting all the different markets. And then some platforms that are geared specifically towards physicians. Our website is updated and we will continue to update it as we develop more for this. Digital marketing is like where it's gonna send the targeted ads, whether it's to their phone, to their email, to a video they're watching. So we're using a combination of actual like picture ads, video ads, and reels to kind of target these people. And then we have some videos made and then we'll make some additional videos. And the videos that we do have is, they're good ones. They're kind of like, oh, need to change your pace, come to Seneca Healthcare District in Lake Elsinore. So I think I showed it to you guys the end of last year. Was when
We haven't
kicked
used
off.
those yet, right?
We have not used those for this purpose yet, so we will use those for this purpose. Mailing list, so we're able to obtain mailing list of, we can get very detailed with it. We pulled an initial mailing list of providers in like the North State essentially. And if you actually narrow it down to primary care providers, there's not that many.
Yeah, there's not.
No,
There's not.
so we are actually going to expand our mailing list to California, Nevada, and Oregon for this first mailing. And we're gonna do primary care providers, we're gonna do, renal practice providers, we're gonna do, there's internal medicine, and there's a list for unknown, so we are gonna hit the unknown just in case.
Interesting.
They're just listed, so they're listed as a doctor or what, but they don't necessarily, the system doesn't have if they're a specialist or what it is. So we're gonna hit those, but, we'll start with the postcard and then we will narrow down the list and do an actual letter. So whether it's gonna be from Brady or Sean, we haven't determined which one's gonna be or maybe it's a combined letter, but I've already had a draft for that going on, so we will do the letter, the postcard. And then we go into our email marketing. So email marketing, we have some email lists that we've also pulled. We will also do email marketing to these providers as well. So this is, again, same target areas. We're first starting with this California, Nevada, Oregon, and then we can always push out further.
And how do you get the email addresses?
So we actually buy lists.
Okay.
So, yeah.
And do we have to ask them if they want to opt in
No,
or just
they
opt
do
out?
not. So if you as a provider have entered your email into certain software, certain companies, certain things like that, you are on this list now. If we send them something through an email marketing, we have to give them the option to opt out
yeah.
in future emails.
Got it.
So our emails will have the option for them to opt out, and then we take them off our list and we don't contact them again.
And do we use something like Constant Contact for this or?
So we can use Constant Contact for this. We can do this through WordPress within
Okay.
our website as
Okay.
well. And so that's probably the
That
route
makes more sense then.
yeah, that will go, is we'll input it into our system and then use that. We can also do it through Outlook.
And I'll utilize it in the platforms that we buy into. I'll pull lists and be sending those emails to them as well.
Oh, great.
Different avenues.
Okay. So then we just have some
Ads for you guys. And these ads are kind of the ones you see, Ethan, if you go down a little bit, they're more of the digital ads. So those are the ones that are gonna like pop up when someone's searching on LinkedIn or Instagram. And what we can actually do is target the different, like, oh, if there's someone who is really, in like they have search history of like compassion or search history of, we can target key trends and key things and push those ads towards those individuals.
Interesting. That's really cool.
Yeah, whereas someone who maybe has more search history of mountains and lakes and rivers, we're gonna target with a different ad.
Is there a magazine that a lot of primary care, like primary care physicians,
Like
whatever, that
Physicians
they-
Weekly,
or so it's like they all have sort of their specialty magazines, and sometimes they get on the listserv. And you might be able to focus very much on primary care emails. Cause usually if they're reading,
Like the American Board of Family Medicine.
yeah, or family medicine, it'll be their listserv or whatever, and I don't know if we can tackle that, 'cause that'll give you a very focused email group.
Well, in some of these platforms,
Thank you.
Did just type in what looking for.
Yeah.
Yeah,
I think it's really
Okay.
granular.
yeah, because they're all on these platforms looking for, and they're chatting, it's kind of like the.
And the platform like categorizes what
Okay.
they are, yeah.
Yeah,
Didn't know how.
What about conference attendee lists?
For what purpose, like for,
Giving their emails,
For
and their
email, so-
specialties and.
well, there'll be,
Association of Family Medicine.
yeah, but also like the UNR, different colleges that are around us and getting into those facets because they are producing the doctors. And so towards their end, their fourth year, they are starting to line up on all of that stuff. So that's another part of
so
it.
that is a part that we have set for a future,
Yeah.
like a future part to work with the
The
school
schools,
colleges a little bit more.
Yeah,
on
like
that.
OHSU's got the,
Right.
out of, Klamath Falls, it's rural health. That's
Right.
all it is.
And conference attendees, we can look into some of that.
Okay.
So what we do though is we actually purchase a list. So like the list we're purchasing,
May already have those same people on it.
it'll have, most of the providers that if their stuff is available, it's on this list. And it's, cause like when you look at the list, it breaks it down by their specialty. So there's podiatry, which is nice because if we purchase this whole list, then later on, if we're gonna target, dermatology, then we can go back to this list and we go, okay, there's already these people on our list that we have contact info for, so we can send that to them. So, but the list is very detailed when you get, so, and it breaks it down by zip code, so it tells us where they're located and all of that. Kind of crazy,
It is
but it is
crazy.
available about people online, so.
Yeah, I was just gonna say, what list are you on?
Right? Back to Shannon, we're going,
So Ethan,
job
you
boards.
scroll down a little bit. So job boards, we identified two that we are gonna move forward with. It's Practice Link and Dot Cafe. Practice Link, we'll do the one job. I kept the two job up there because they do include physical therapists, so I thought that would be another route if our current route didn't work out. So, and timing of this is we're going to time it mid-May to late May, and then May and June is, we're really gonna be pumping out the marketing and trying to get some people in here. So this is where we talk, you gotta keep scrolling with me. So I have on here residency and fellowship programs and identified, game plan of what, we can do, develop relationships, attend job fairs, identify the schools, contacts. We currently have a relationship with Enlo for Healthy Rural California, so that's kind of already in the works, and we'll have to develop the other relationships.
So what does that entail? The one with them,
They are doing a residency and family practice, and so they have two residencies. The first one, psychiatric one, has started already. And this one, they are in their selection process for their seat, so I think it'll be end of 2025, they start the first. And so that will be rotations.
okay, like a month-long rotation or?
I don't have the
Okay.
details yet. Just like Reading, the school out of Reading, we get them to rotate.
Yeah.
Or last year, we had the one UNR that vacationed here and his sister is couple years behind him. So hopefully we have her come through.
That'd be great, okay, thank you.
But more of those types of relationships.
And then kind of a last resort, we're trying to avoid this as recruitment agencies, but have some up there. The numbers are what was spent, just an idea of what was spent through those agencies
For one mailer,
last go
one
round.
letter.
Yeah, and so this program that you guys are building is exactly what we did at Enmo, because if you have a physician recruiter that is very talented and they do this, or you hire a company that does this, but a lot of this is exactly what these two do on a daily basis. If you just build it internally, then you have more control over it. And that you're not sourcing that same doctor to 5 different areas to see who picks it up, so,
And you're more likely to get someone who's a good fit.
yeah,
Yeah,
yeah.
I think this is amazing. You guys have done an incredible job putting all this together.
Yep.
Thanks. Then locum agencies, that's a last resort.
Might have to be a temporary.
Yeah, hopefully not. Step 3, it just goes over the next step, screening the candidates. We have some tools that Chelsea and I have put together, phone scripts, talking points, resources that we can use when questions come up, in the conversation. And this just goes through the steps. Step 4 is that on-site in-person interview. Just the details of that. I think we have that pretty much nailed. We've done it multiple times and I've been doing it with the controller and the PT position, so we kind of know that process. Step 5, this,
Scrolling even a little more for us.
Step 5.
Thank you. Thank you.
Step 5, now we pass it to Sean and Brady to do the negotiation, evaluation, and the choosing. Once we got somebody, then it goes over to Joanne and Sarah Lynn, the credentialing process. Chelsea will start marketing the provider.
Can I stop you for a second,
Yeah.
Shannon? If we can get our credentialing digitized,
We are.
okay,
Yeah,
It's actually
That is-
about
because
March.
that's kind of a big,
Yeah,
yeah.
Yeah.
that's something that is,
thank you.
It's well under its way.
Yeah, it's happening right.
so right now, we do have on the website, we do have like the PDF versions up in case they're needed, and
Sure, you know, I
But
get
yes.
it. I
that
get
is
it.
a
I
process,
just,
because I agree, if I were to go there and see all that, I'd be like,
Get it?
I gotta print this out, I gotta write it in my.
So it's actually,
Yeah, no.
it's actually live.
Yeah, it's live. Joanne put our data in it. We're testing the live environment, making sure it's ready, and then that will be a launch.
I'm happy to help test if anyone wants.
Great.
Okay, and then, Steve, Sarah Lynn is also from the payer credentialing, which is the other piece of it. There is a platform that at some point in the future will be stood up.
Okay,
So it'll be a little more user friendly on
Okay.
both sides.
good, thank you.
But in this, so the first part was the there's 3 phases of this, the recruitment part, then the onboarding part,
Mhm.
then the retention part.
Yeah.
And so that's the kind of program entirely.
Mhm.
Perfect, thank you.
And then, yeah, step 7 is just that retention and ongoing support. I assign that to Brady.
And I have Brandy working on, so we have a provider packet that, for like when they do get for onboarding, things like that, so she's working on getting updates, and that's just something that we'll update yearly. But just so that when we do have a new provider join, it has all of that, like, kind of like what different departments have determined are the most commonly asked questions for the essential information. It has even little things like, here's the phone number to this, this area, the pharmacy in town that you might need to talk to here and there. So it's got all of that stuff in there. So that is something that will be part of the onboarding once we get there.
So any suggestions, feedback, ways we can improve?
It's thoughtful.
It sounds great, yeah.
I'm impressed. I think you guys have done an
Yeah,
amazing
I
job
think
putting
it's
this together.
amazing.
Yeah,
Thank you.
and I'm really excited to see who we get through this process.
Well, let's try everything else.
Well, you know,
Yeah.
this is, spending the time and the effort to do this in this way really is gonna show someone who's interested that they really should be interested in coming here. And I think this is amazing, so
Yeah, we're just not paying a recruiter. We're.
But we are gonna,
we have to invest in.
we are gonna
places,
spend
Yeah,
money here. We are gonna invest in the list that we obtain. We are gonna invest in the digital marketing. So it is still gonna cost us, but
But it's.
Yeah, my
it's
experience,
direct.
my experience with a recruiter is they're basically just a marketing company.
Yeah.
And when you don't get any hits, they ask for another $8,000 for another blast and then another blast.
Right.
They don't represent you.
Yeah.
They have a hard time defining you.
Our
So
loyalty is spread.
And a lot of
We
times
can
the
define
marketing
this.
content you get from those recruiting agencies, it doesn't tell you the exact, like,
location.
Yes, it doesn't even tell you it's
It's
in a
very
healthcare
rare.
district.
It never does.
It says.
Because they don't want your
That's
providers
true.
around
It says
them
Northern
for further
California.
That's
interaction.
true.
Yeah.
So
Northern
it's-
California,
yeah.
most people San Francisco, so it's like.
Yeah.
oops.
Whereas ours will be very, you know, we're gonna give them all that.
Yeah.
Very
How
forthcoming.
does the lists? I have no idea.
So it really depends on how detailed you are, with, and what like parameters you set. So just a list of Northern California providers is $450.
Oh.
So, but,
How many did we actually get approximately?
so that list, he quoted me for, and then there's 2,800 providers, but that's every specialty
Everyone.
in Northern California area. So that list, I still think is beneficial for us to obtain, but then we will get a list of just primary, the general, and that will be for California, Nevada, and Oregon.
But we can also focus on our specialty, like Durham,
Right,
since we have the list.
right, and and then if we go, oh, we can start there and go, okay, we have this list, look, there's, you know, already in Durham in this, you know, North State, let's reach out to them. But
Are you using this in California, this letter, Nevada and Oregon? So I'm just reading that and wondering if we need to incorporate the word California in this one, yeah.
oh, yes, so I think what you're looking at is, those are standardized messaging for like when we do an email, and yes, when we do those, it'll have our branding attached to it, and it will also have like, it'll have the details of our location, all of that
The
within
address
it.
and everything.
Yeah, but, yeah, we could put Chester, California, yeah.
Yeah. And we'll definitely make sure to do that.
Thank you.
Anything else?
Anything else for,
Okay, thank you.
appreciate it. Thank you so much.
Thank you. We funded school.
I don't know if you heard Rich, but he said great job. All right, so let's see. Yes, I'm
Sorry,
sorry, Justin, where you
might as
going?
well just stay
Your
here.
turn. All
All right,
right,
that's it, no.
all right, I'm marketing and PR.
We're just doing highlights still. We're doing highlights.
Highlights, yeah.
Yeah, so, we're still doing our radio marketing. We've got new fresh ads going on. We have students writing ads right now, so we did this last year, and our student rotations, they're writing ads, they're pretty cute so far. So when their program ends, we pick winners, and those winners get to go with us to the radio station and actually record their ads. So that'll be fun.
I think that's fun.
We've ordered more rack cards. We're running out of rack cards. We keep going, so, which is great. We are also working on a new hospital brochure. So what Brandy and I have been doing is logging like the most common questions that we're getting, the most, you know, people want to know how many beds are in your skilled nursing, how many this. So what we're gonna do is put those most commonly asked questions and updates into a brochure.
Like an FAQ.
Yep, and then that way, when we're out at the information stations and things like that, we can pass them that as a take home, because even though we're answering all these questions, and that way they have it and they can just reference it later, whatever they need, and put some imagery in there. So that is something that we're working on. The maps are in, and we've already started distributing the maps we talked about with
The maps
hotspots.
look great. I saw them.
Mhm.
They look really nice.
So those are in. I meant to bring one today and I did not bring the pack. But we're getting great feedback on that. People are really enjoying those. So, and those are going out to Airbnbs, real estate agencies, coffee shops, anywhere that tourists might hit. Oh, look, yes, Deborah has a pack. I left one here, so
We're just passing.
yeah, we can pass it around. So kindergarten roundup went great today. We had, Stephanie White was there, Casey Broussard, and Tracy Haynes. So Stephanie did the physical proceedings, Casey helped with the blood pressure, and Tracy helped talk to the kids about dietitian needs, and she helped parents fill out the anemia forms, because a lot of parents
Don't
don't
understand.
understand that. So it was actually a great combination of people to have there, and it was, we had 2 auxiliary volunteers. We had Cheryl and Nancy there as well, and they were great with the kids, so. It went over very well. The school was very thankful. The kids all got little goodies and take homes, and then they got information on primary care, and the parents got information on why it's important. And
How many kids?
there were 15, little kindergartners that went through.
Oh, that's
And
great.
then there was probably, because a lot of people would come, like, it'd be multiple, like, parents, and they bring siblings and stuff like that, so we gave out extra stuff, but
Yeah.
yeah, So it was cute, and I think we got a few new, patients out of it, so that'll be awesome. Some kids really liked Stephanie. They
Good.
thought she was good. So, monthly information stations, so those are still happening. We do have, one next week at Lake Almanor West Grill at 9 a.m. So that's our next one, and then June, and then I will at the next meeting have the list of all the other, we already have those lists done. We're just verifying with some of the businesses that they're okay with the times and the dates that we're working on for those.
Great.
And then band shells, we're ordering the prizes for the band shells. We're gonna do more summer prizes. Town halls, we're gonna be at on Monday. And digital marketing, we're still doing digital marketing. I attached a digital marketing ads planner in there for you guys to see, so you can see the different ads that are going out on digital marketing throughout the month.
Are you able to schedule those out?
Those
So
are
you-
all scheduled out.
So
we-
you don't have to sit and, bless you.
Yes, so we schedule we scheduled the month before for the next month, all those ads are scheduled out. Now, there are some times, so like if we do something like kindergarten roundup that'll go out, that's an addition because we don't write that until after the event happens. So a lot of the press release ads, those are things that are more in like real time, whereas the content that says, oh, happy phlebotomist day or whatever it is,
Yeah.
that is stuff that
You're
we
able
do
to set that.
schedule out.
Right.
So we pre-plan schedule. Other than that, so lots of good feedback from the community. People are excited about the new building. We already have somebody that bought a beam.
Oh,
Yeah, Plymouth Bank.
that's from Spain?
Yes, Plymouth Bank. So hopefully we'll get some more. We haven't even put out flyers for that yet. So that is exciting,
That is very exciting.
right?
What does it cost to buy a beach?
It's $500. So the foundation board, voted on it, not last Friday, the Friday before, and $500, so that way it's a number that is feasible for
That's great.
businesses. Okay, employee appreciation. So we are working through employee appreciation gifts. We're hoping to release those soon. So Shannon and I had talked about releasing those halfway through the year versus at
Yeah.
Christmas time. Cause that kind of breaks
Good
up,
idea.
it breaks it up, so it's not all right there with the Christmas party.
Mhm.
We're just waiting on some final pricing from our vendors so that we can get it all under budget. So, cause everything's gone up. MRI service packet, so we basically have a mini campaign ready to go once the MRI machine is ready to go. Then we'll put it out to providers, the public, everybody, let them know what's going on. Patient portal. Okay, so this one has been interesting. We've been working with Cerner, so Candace and I have been working with Cerner and Brian to try and get patient portal and Brady. The latest update, so we got a quote from Cerner that they wanted 13,000 to get this self-scheduling feature going in our patient portal. It's weird because in one part of our contract with Cerner, it looks like it's not included, but in another part, it looks like it is. So I'm gonna review the contract a little more with Brian and see if, like, what we can do there.
I think Cerner owes us some love.
Well, and I'm
All the stuff
pretty
that's-
sure in the initial conversations that this was always something we told them, yes, we wanna do. And I thought they had said, yes, you guys have this, it's part of your contract. So, and it's weird because part of it, like, so on page 38, it looks like it's kind of vague and it might not be included, but then if you keep reading on page 40, it looks like it is. So we're gonna have to work with Brian and kind of narrow that down a little bit more and figure out what to do there, but we're still working on it. It's just been kind of a battle back and forth with Cerner right now. So, appropriations application's done. We haven't heard anything. I will update the board if we hear anything. Tracy's video is done. Our videographer had some family things go on, so he is running behind on Dana and Stephanie and Heather's videos. Those are the next videos that will be coming out though. Wellness screenings are coming up in June. So first 2 weeks, we're gonna have auxiliary there. And then we are working with Charlene on, interpreter services. So for my department, it's mostly just updating websites, things like that. And then, the new build updates this month's is already ready. They go out the end of every month, and I think we're up to about 60 people that have requested it. So people just sign up on our website and request it, and then once a month it goes out to all those people. And then, yeah, provider recruitment, so it's marketing,
For screenings,
yes,
what payment methods are we accepting?
cash and check.
And I ask this every time, why we can't transition to another method, because people coming from out of the area, they're not gonna have a checkbook, and they're likely not gonna have cash,
We
So
do
like
not,
Zelle or
anything, anything.
we have not gotten anybody, so in the entire time that I've been here and been involved with the screenings, that has never been an issue.
Really,
People that come to the screenings are typically local business owners. That's the most of our screening people. I've, never had someone show up that wasn't prepared for it. Now, that doesn't mean, I'm sure people would appreciate the card option. And I just don't know, you know, because we do it remotely over at the other, and we can put that and talk to.
just maybe put some conversation around it, just
So-
because I feel like there's a possible way for us to maybe reach more of our visitors to do these screenings.
Okay,
But if we do, we'd have to have another way for them to
to pay.
pay. Yeah, anyway, just.
It's pretty hard to get that fee.
There is,
Yeah,
there is,
pretty much.
we would have to absorb that, but I mean, we are a community facility and we are providing a service, so. I mean,
Right.
I don't see why we wouldn't necessarily think about covering that.
Okay.
That's my thought.
I think it's worth the conversation, now, you know, like I said, we haven't had that issue, it's never been a complaint, but the people that use it, it's typically, honestly, it's like the same people every year, and they're prepared for it at this point, they bring their cash or their checks, so.
I just think maybe make it a big, maybe not this year, I don't know. but maybe
Yeah.
We can make a bigger community education, community wellness kind of, push it more.
Like kind of change the event a little bit, is that kind of what you're thinking?
I'm thinking that really, it would be nice to make it so that everyone all around the lake is well aware of it and wants to come do it, because it's a cost-effective option for them to get that done, regardless of who their provider is, and so they
Right.
understand, it doesn't have to be their provider is here.
Right.
So I think there's opportunity, is what I'm saying.
We can work on that more, and we can definitely, push it out further, so we.
And like I said, doesn't necessarily have to be for this
Right.
year's, because obviously it's coming up quick, but
Right,
just something
Yeah.
to think about.
okay, yeah, and we can look into that, I don't see a problem with looking into that and seeing what, you know, if that, you know, is something we can offer, and if it helps, so.
Yeah.
Any other questions?
Board members, any questions?
Okay, other than that, you guys got lots of little attachments in there, those are all just things for you guys to look over, be aware of. And,
Did you want to mention
the donation
foundation?
policy, yes. So, the foundation went over the donation policy. Ethan, can you pull that one up? So this is something we, voted on at the foundation board meeting. And basically, it's our process, for handling checks that come in. Just to, have it, you know, here's our process, here's what's going on. And it just kind of spells out how it's gonna work when a check comes in, so that way we make sure the foundation gets all the information we need, so we can send the thank you letters, the appropriate tax receipts, all of that. And then we make sure if there is a question on where the check was intended to go, we are following up correctly, so we still are getting, like, we'll get in the foundation envelope, so we have these remittance envelopes that have, like, where people can check the boxes and fill them out. We'll get checks in there, even though it says, please make your checks payable to Seneca Healthcare Foundation. Go right to Seneca Healthcare District, we get ones for Seneca Auxiliary, so this is just our policy to just make sure we're following this policy when we're dealing with anything like that. So if there's a question, we do contact that donor and we make sure to clarify what was your intended, was it intended to go to the 501c3, was it intended to go to the 170C? So that way we're making sure to honor the donor's intentions.
And regardless, you're sending a thank you to
Yes.
them regardless
Yes.
of how.
Regardless of whether it comes out of the district or the foundation, everybody gets a thank you letter and everybody gets a tax receipt.
There's a nice table, there's a nice little information table at Plymouth
Yes,
Bank.
there is.
Yeah, I
Yeah.
picked up another one.
There you go. Yeah, I think this turned out nice, Kelsa, and including the graphic is very well, very well done too.
Yeah.
Any other questions for Kelsa?
Okay,
Thank
I'm
you,
sure
Kelsa.
there's stuff I'm missing, but you guys can call me anytime.
Thank you. Okay, let's see, I think I saw something, please. You ready to do your report, Steve? Thank you.
Like all this, you guys all talking about exciting stuff.
Well, yours seems exciting too, at least for me.
February's not so exciting, but, so. We are talking about February's financial statements, but I wanna make a comment or a statement that during the treasurer's meeting this week, recommendation was made by Rich and Jerry that, till I can get to where I'm back into my rhythm of presenting the previous month's financial statements, full financial statements. So in this case, here we are in April, I'd be presenting March typically. So until I can get in that rhythm, and that's certainly not gonna happen until after we get through the budget process. So it will most likely be a couple months before we get there. What I'm gonna do is provide information about the month I would have been reporting on, because I have, by the time I get around to the board meeting, I have almost all the pieces of the financials information, with the exception of the non-labor expenses. That's really the challenge, to get everything together. And then, of course, get in all the adjusting entries or whatever they may be, and produce a full set of financial statements that I feel good about. So, I worked up a little cheat sheet here. It's not gonna be presented today, but I certainly can talk about it, because Rich and Jerry thought they would be beneficial. That I can go ahead and present the financials, which is important for the month I do, but then to roll it forward until the next month. So at the end of this, and when you guys are done with me here on February, I'll talk a little bit about March, and actually have some preliminary information for April as well. So there you go. Questions or comments or thoughts or concerns about that? Yeah, it's a great suggestion. So, okay, back to February. So February was a dip in our revenue, a dip in our utilization. We talked about January being this baseline month. January was also a month where we had the impact, or we saw the impact, at least from a revenue and utilization standpoint, of all of the bugs that were going around town. So we did see a decrease in that, and it was fairly significant. So for February, our total patient revenue was negative to budget, $221,000, with the adjustment to revenue positive, just because revenue is down. The adjustment to revenue, hopefully, are going to be positive. The net effect of that was that we had a negative net patient revenue of just under $160,000. It impacted all areas, both inpatient and outpatient. Big impact was inpatient. As we talked about when we looked at January's financials, we mentioned that would be the last month that we would have that long-term swing bed stay, which was great. It was kind of making up for the shortfall within the med-surg acute side. But in February, we only had 3 acute days and no swing bed days, so it's very low utilization. We had quite an extensive discussion about that in the treasurer's meeting. we did see a little bit of an increase into, I don't wanna jump around, but I think it's important because we're here. We did see a little bit of an increase into March where we had 9 inpatient days and 7 swing days. I mean, it's good. It's at least, more admissions. That's really our issue, is that we just don't have the admissions. Speaking of the med surg acute, the swing bed is all about getting the right placement, and right now, we're very limited in the type of swing patients that we can accept. There was conversation about adding the physical therapy piece, which would be dynamite.
So Steve, real quick. So I mean, maybe for 26 budget, as you're working toward, getting that, working on the 26 budget. Maybe we should budget for fewer acute inpatient days. I know the downstream effect of that, but it
It's
just
less than
seems.
0.
I know, but it just seems like we didn't make it, we were.
Well, I think I budgeted for 0.5 census. I mean, it's.
That we don't make it.
And I don't want to jump into the middle of this, but I think that we are discussing a strategy around our admissions as well. We think we understand a little bit more about why our admissions are low. And it has to do with our hospitalist hybrid.
Oh,
And so we're taking a look at different options, working with our chief of staff, our medical director of the ER, talking about why physicians don't admit. There's only a couple that really do. In fact, Steve validated it very quickly. And we believe the reason is, and we've already brought this up, is that if they admit, they have to follow up, and they're ER doctors.
yeah.
So we are gonna be taking a look at maybe a different model by which they would admit they wouldn't have to follow, and that might help them with admissions, because we already have the very defined criteria.
But who would follow? They didn't follow.
Well, nurse practitioners can follow, a lot of them can follow. Under the guidelines, and it happens a lot, nurse practitioners save the world.
Yeah, well, but the crew that was in February is not the same
Right. We have a lot of-
cohort as what's in there
We're
now
missing some of
either,
our
so
students,
it's old data that we're talking about.
Okay.
But we're thinking of it from a perspective of process.
Okay.
So, yeah, but sorry.
Makes sense.
Um,
Thank you
We're
for that.
gonna increase it.
Yeah, we've kind of brought it down each year I've been here, So,
It worked.
now the only saving grace is that we do make it up a little bit, as long as we have a strong Medicare mix, because they pay us cost for our Medicare services. Almost 100% of our swing beds are Medicare. It's really a Medicare program. Anybody that uses it it's kind of weird,
Right.
that they even use swing bed. And they certainly don't pay as well as Medicare does. So if we have a high Medicare mix, even if it's low, we still recoup all of our routine costs, all the nursing and the costs that are allocated to the inpatient unit. So we don't see it on the gross side, but we see it on the net side, because our reimbursement keeps climbing. We used to be in the 60s and now we're up to 70%. So,
Do we admit to OPS very often? Do we not like to do that either?
When it meets criteria.
yeah, hit and miss.
Yeah.
I'll actually do our inpatient reimbursement. But that's okay. I mean, it's the appropriate place, and I give great credit to case management. Going back to the long swing bed stay, it'll show up in the R1 report, is that we were paid for we were paid for 91 days.
Wow.
That they're gonna come back and review, but we sent it out and they passed all the edits, and we just had to bill it in 2 parts because there was an overlapping a calendar year. So we received almost $550,000.
Yeah.
It was a good thing, but we provide really good appropriate care and had a good outcome for the patient, so. I mean, that's one of those good stories, when we're talking about some of the craziness in Washington and what they wanna do to, rural safety net provider, so. Anyway, okay, so I was just talking revenue. Like I said, the outpatient was just less of a negative impact in the month of February. It was kind of, there's a analysis in the back of the financial packet, kind of across the board. Speaking of that swing patient, we still are getting good revenue off of our wound care program, which is great. And earlier we talked about MRI. MRI's hitting us to the tune of $30,000 to $35,000 a month in revenue that we were previously getting by not having the unit available. So when we bring that back, plus it's a better unit, we're hopefully we got the warrior to drive through the winter to come up here and either rain or sleet or snow for MRI. That we can get that reliable, just as what we've seen with ultrasound. Ultrasound's been a great success story, so.
And it's weekly, we'll be getting it, is it weekly? Weekly, so people that we lose, they don't wanna wait.
Well, the new PFT machines also.
Yeah.
I spoke with Julie Richter, she's so excited, she's so grateful for the auxiliary, monies for that.
So, again, kind of jumping around, staying on revenue. So, like I said, that the, February was down when I kind of threw it up, if you will, making 28 days, 31 days. We were well below January. When we go into, March, we're starting to see an increase. We're getting back closer to January. And then we have some very preliminary numbers for April, and that's extrapolating out for the remainder of the month. We're almost back at the January figure. I didn't have anything in there for the future look. But again, that getting to the January numbers just gets us to our budgeted revenue. So, and we're well ahead of last year, but we budgeted for an increase, which I don't think was unrealistic because we have the providers in place and we've seen some good months. But now as we get into, go beyond April and get into May, when we have the real demand of the community that comes to us, then we'll be prepared for it. I think conversations I've had in the executive team when we met is how do we not be like, some of the restaurants around here where they just kind of limp along in the winter, kind of thing. And not that we limp along, but I'm just saying that there's a definite dip in their business. They stay open. How do we continue that flow of utilization in those off months? So that, no easy answer there, but the biggest thing is to have, what we've done is to have the consistent providers, have them available, have the services there when the people need it. Repatriate, as Sean loves to say, which is a great word. So that's kind of the story. And obviously we'll see the numbers go up as we come into summer. But again, it's now, how much can we realistically, jump into budget now, how much can we realistically project for next year to see revenue growth? Because it'll be our second year of a consistent panel of doctors. Stephanie White's new, but over there at the school getting business for us, or she has hit the ground running, and her numbers are really great for an initial provider. So all kinds of positive things there. Questions about revenue? Okay. So when we go down to expenses, this was kind of the good story of February, is that we're continuing to do, I think, a good job of managing our expenses. The budget, as I've talked about previously, my budget for 24-25 has a little hiccups in it. So when we look at our labor costs, and what I like to do right now is I like to lump everything in there under labor, because normally we just say, okay, salaries and wages, employee benefits, all that. But because we've done, you know, you saw the recruiting effort and what, maybe I didn't see it, or maybe it's been presented before, but the recruiting effort on the non-physician side, but on the clinician side has been incredibly successful. We, I have to read this because I can't believe it. We only had 2 equivalent contract labor people in the month of February, which is just fabulous. I mean,
That is amazing.
you know, and that's a testament to a lot of things. But it's definitely a testament to hooking them and keeping them. It's the same philosophy with the physicians. So, that's really amazing. So we've converted a lot to employed positions, so we consistently run over on that. We have positive variance on the contract labor, which is the registry, which historically is just nursing. Every now and then we'll run in with a CLS or a radiology tech, or something like that, phlebotomist, surgery tech, historically, but just recently, it's almost all, nursing. And then the other thing that I've mentioned in the previous, presentations is that bringing on Stephanie White as an employed nurse practitioner, we had budgeted that we thought we'd have to go out and get actually a contract physician. We didn't think we would be able to get an employee. At the time we were preparing the budget, we thought that's where we would land. And so that's a cost savings to us. So you kind of add those all up and we're sort of in the ballpark. One of the hiccups, if you will, of my labor budget, and this is something that I've been working with Brady, talking with him through it. We're gonna pilot the clinic because they're ready to go and I've got information ready for them. And so at Seneca, we have 2 forms of pay increases. One is our step process, where there's 8 steps. I think that's A through H. And if it's on an annual basis when people hit their anniversary, their annual anniversary, if that's not redundant, they get a 4% increase until they hit that last step, and then it freezes there. There's no more increases. So that gets on their higher anniversary date. The other increase that we have, well, it's kind of twofold, is that we have a union negotiated, what I would call a COLA, cost of living adjustment, because it's across the board, everybody gets it. Union, non-union, all employees get it. And that's just negotiated. It was 3%. This is 2025 is the last year of our contract with them, and we'll be negotiating a new agreement. And then kind of melded in with that is the whole mandated minimum wage thing, where we had to first move our lowest step A beginning entry level salary pay rate to $18 an hour. And then we have to go up 3.5% on what it is for 7 years or something like that, till we get up to $25 an hour. Whereas the big hospitals and chain system hospitals had to go right to 25. So back to the OSHA comment where they say we gotta cap our.
What I was thinking.
We gotta cap our cost increase in 3. Okay, we're out 3.5 because of you. You guys have passed that, but no, it's, so that's the other piece. And so what we're really gonna work on through the budgeting process is we have the ability to pull out, not just classifications, so like RN, LVN, all of those, is that we actually can identify with specific people as it is today. You know, things change, right? So we can identify their anniversary date and we can target, you know, where they're at or we can see where they're at on a step scale and then budget in a 4% increase for them. Everybody gets a 3% increase effective January 1 or whatever gets negotiated. And so when we do our budget, I'll be a little more meticulous about when these increases fall, so that when we're comparing the average hourly wage, things are matching up, so that when bumps or increases are happening, it's reflected both in the budget and the thing, and in the actual. And it's because one of the changes we have is, or one of the variances we have is the average hourly wage this period, and we will have probably for the remainder of the fiscal year. The other piece is FTEs, but we see the savings on FTEs through the reduction of contract labor and the addition of an employed FNP as opposed to a contractor or locums position, so.
Are step increases pretty much just an annual thing for everybody? You get a bigger or higher step, or is it based on competencies and skills?
No, it's automatic.
The first, yeah.
It's
not
automatic.
Tied to competencies or skills, it's your anniversary,
Oh,
you know.
We've tried talking to the union about
Yeah.
including something
Yeah.
like that, but so far,
no, okay.
Steve, how many steps did you say there are?
ACEEFGH,
Yeah.
8 steps, is that kind of standard to the industry, you know?
So now I've seen them go out farther, and I think that we've talked about that in the past. We said, hey, wouldn't it be great, since it's just a reward for longevity kind of thing, is, let's kick it out to 16 steps and make the step increases 2. So, yes, you get a little bit less, but you get it for a longer period of time. That doesn't sound right, you get less for a longer period of time.
we know.
But no, it works out in the end because.
You get more in the end.
2 times 16 is 32 and 4 times 8 is 32. But it's a problem because previously when we were recruiting, someone would come in and say, hey, I need this amount of money, and it's like, bingo, you're on step G
Yeah.
or whatever, and you're frozen there. So I think the idea of more steps at a less thing, we've talked about that as well, but everything's subject to negotiation.
So is it
I
the
guess.
unions that say it can't be based on competencies or skill sets, or that it has to be
Well, they'll
just like
fight it.
annual thing?
They'll fight merit-based anything. But I've seen some inroads in negotiation in the last 5 or 6 years where you can lay a little bit of merit in there. It's not gonna account for a lot of the step,
Yeah,
but you can put a thing in there that says if these conditions get
Yeah, for nursing like ladders.
ladders.
yeah, that's a lot.
Yeah, so sometimes organizations propose that to unions, and sometimes they go for it, and sometimes they don't.
Why did you put in there some language about the disciplinary actions in the time period?
I think there is actually, when they get to it, there is one piece, I think that Shannon can maybe she's gotten that deep into it, is I think that if you're on some kind of probationary or disciplinary pattern, you can, I think the step can be
So there's a reprimand.
held back, if you're on progressive discipline to a certain point, I think I saw that, I don't know. Okay, Shannon's giving me the grimace face, so. HR.
Yeah, the upshot, generally is anything that is subjective, they're gonna reject.
Yeah.
The objectivity around ladders is if you attain this level of education, you can show that you moved into, you got these additional skill sets. That's easy, but I can tell you, trying to negotiate anything that's subjective is just, you're gonna just go around and around and around on it. And they consider performance a subjective thing.
It shouldn't be.
Oh my gosh.
Well, you can drive metrics around these things, but it's very difficult to drive those metrics.
Well, it opens the door to favoritism claims and
Yep,
all kinds of other
Yep,
HR
exactly.
kind of problems,
and you just like that person better, so you give them a better score.
right? Or what was your criteria for marking them down?
And that's
Was that?
a perfect word. That's the word we hear a lot, was the criteria.
You bet.
Criteria is be a good citizen. Or a good citizen.
Come to work.
So there is, it's actually, that's the one quantifiable thing that you could potentially put into the merit-based small percentage increase or not is attendance, because we track it.
Yeah, because it's black and white.
Okay, last comment on expenses, as you'll see, supplies had a very positive $34,000 budget variance. But if you slide over, you also see that supplies are very near budget oh, thank you, Ethan, on a year-to-date basis. So we've talked about this as well. The big issue here is that it seems like the last couple of years, when we go into a new fiscal year, there's a large amount of spending on like minor equipment and really like instruments and things like that, in the surgery and the ER, that we need to get a handle on. When I do the budget, I'm just gonna say, you know, what's up with this? And, you know, do you really need this? If you need it, are you really waiting till July to get the darn thing? You know, or we should be talking. If you need it now, we should talk. If you're gonna need it summer because our volume's higher or whatever the issue is, I just need to know so I can front load supply expenses. We'll budget for it. As you can see, we're not going out of bounds on year to date. So we're just gonna talk to them about it. Again, it's a timing thing. Do you really need to, you know, is this the way it's gonna work? And if so, we'll again front load the expenses and see how that works for us.
And I think that's gonna get more in line when all the managers are looking at program, you know, looking at things as programmatic. The program requires this, or we're gonna grow this program during this period of time. It's more defensible, I think, is the word.
And that's the discussion that Judy and I are having with the departments to say, okay, you guys internally do your own process. What's gonna break? What do you know, for the whole bit, so we're prepared for those conversations.
Does
Some
each,
guidelines you give them to do that?
Yeah, these are the things, because some of them don't think that far ahead, you know, what break fix is one thing, if it's, you know, if it's wearing out, that you're gonna, you know, let's like at least propose it to Steve now, and so that way, but you gotta open their mind a little bit to think about it from that perspective versus.
Instead of the day-to-day.
Yeah, instead of the day-to-day. of
do the
what's-
managers manage their own contracts for their own like equipment or?
The managers are involved in the contracts, but when it comes to the review, like they may be forward facing with the representative of that. They may get the information, they may get the contract, then it will go through a process, and then at the end, the signature authorities of it. So that we make sure that the elements of the contract that we want as an organization are in there.
It also gives us an opportunity at the final level of asking more in-depth questions. We've got a much more robust system by which the request includes IT, for instance, you know, we
Yeah.
never did before. But now it has to, because now that there may be costs associated with
Right.
information technology, interfaces, you know, maintenance. It was all done kind of in each individual department, and now it gets built, thought of, built, and then pushed up, so we can ask additional questions.
Then if it's a negotiation where you don't necessarily want the manager to do that, because one, they may not have the skill to do
Or the
that.
signature authority.
Yeah, but we can do that. you know,
But it's
we
good
can
for the
do that.
manager to know the nuances in the
Yeah,
contract
Yeah,
as it relates to the
yeah,
equipment.
they'll know the clinical
Yeah.
aspects and what they need, and then we can arm wrestle with
Okay.
a price of it.
Exactly.
Okay.
More of the process. I was using.
So is this part of like an executive team, agenda contracts? Are they reviewed monthly, annually, or
Well,
all the different contracts?
That's a really, so we're actually getting a handle on all the contracts that have been out there that maybe, there was no visibility of administration prior, and it's sort of been baked with that department head, but now we're starting to get an understanding of the contracts when they're due.
yeah, all of
Or
that.
software.
We're working all
What
language.
about contract
Well, there's
management software?
there's a software called Contract Collaborator, which it's houses it. Now, it's probably a cost, you know, associated with that.
Yeah,
But I think the first thing is getting, everything so everybody knows there's a process. And then, you know, they can reach out to the vendors, but they should be talking with their managers or their VPs on, hey, I'm gonna reach out, or who wants, you know, there should be a strategy to it.
yeah.
And then once you get the document, then it's reviewing, you know, the elements. So we have it more in a manual process than the archive of it, because like Steve's group is once we get a contract, we need to make, like Deborah Howard's book, she also emails it to the appropriate people that need to have it for payment or whatever. So we're building that process. We can do that internally before we advance to something like that, where it's actually pinging you, hey, your contract's up in 90 days.
Right.
So,
That'd be nice to get to eventually.
Yeah,
Yeah.
with a lot of more scrutiny on, terms and termination. A lot of scrutiny, because we really, in the past, have been really taking advantage of as it relates to our ability to term certain things. So you owe us the remainder of the 3 years of your term.
yeah, no auto, there.
No auto renews.
In this California and the
We're
county.
losing a lot of money
Yeah.
on contract.
Oh,
Yeah, leakage,
a little bit.
so we really had to tighten.
It's just tightening everything up. Steve, sorry.
Not at all. Great discussion. That's really it. I would be remiss if I didn't, I beat up the inpatient revenue and all that, didn't recognize that the long-term care unit has been holding, at budget or better, and again, last couple of months has flirted with complete 100% occupancy, 16, and they're back there again, so. Great
Great.
job by everyone over there and the people doing the Medi-Cal bars and, as I mentioned before, the long-term care is probably I mean, that speaks for itself, but has been the big success for revenue cycle that we got that all worked out, and my goodness, partnerships paying us in like 20 days on long-term care claims, and that's
That's
nothing
amazing.
to sneeze at. That's $250,000 to $300,000 a month that just
Amazing.
comes in like clockwork. So they still pay us with checks though, but we're working on that.
So.
Great.
That's it for the financials for February. I don't think there's anything else I wanted to go over with, on the March information. I think I covered that. So any questions or comments?
I don't think so.
Okay.
With that, I'll take a motion to accept the February 2025
So moved.
financial report. Thank you, Rich. Do I have a second?
Second.
Thank you. All in favor, Ken?
I,
Sherry?
Aye.
Shelley?
Aye.
Rich?
Aye.
And I'll vote aye.
Thanks, Steve.
So that moves us to our cash flow.
Yeah, just real fast, Ethan, if you just pop that up there, rotate it, and blow it up a couple clicks.
It's me, and I
Oh, Deborah's.
honestly can't see where I'm supposed to flip it, right there?
No, it's a new document, so go up to,
Still
Citizens.
says
Oh,
cash flow.
yep,
there we go.
Thank
Now
you.
we're ready.
Now we can flip it.
Oh, where's that? at?
All right.
All right.
1 and 1 to the right, 1 and 1.
Just like getting a lot, see here.
That's okay.
There we go.
okay, so we've kind of beat the old cash flow ad nauseum in previous months, so just no big changes. The one thing I wanted to point out is that, over there into April, there's a line there under rate range supplemental payment. The rate range that's reflected here, the supplemental payment is for calendar year 23. It was our last year with Anthem and California Health and Wellness. So Anthem, sent us the initial payment that we IGT'd for, and then they, said, hey, we found some more money in the closet or wherever they found it. And, so when they were cleaning out the books, so they sent us $129,180.
Looks like we'll take that.
So that was very nice,
Couch cushions.
couch cushions, right?
Wish I had that.
That will be subject to our agreement with the, company that enhanced our, IGT program, so our net benefit has gone up, so we'll give them 15% of that, which we gladly do. So,
That increases our budgeted amount for next year then too, right?
no,
Oh, wait, no, that's.
it's a whole separate deal with partnership. We did submit we submitted, our, uncompensated costs and uncompensated charges for calendar year 24. we requested an IGT of 2.5 million, which should equate to a slight increase over the amount we received this year. We're just waiting to hear from them what they sign off, so it should be at or better than what we had in what you're seeing there on the screen. The 4 million or 4.4 million and the 1.5 million. So that's good news. Plus, we're gonna get that little bit of money from Kaiser.
Did we get the QIP supplemental?
Yeah, we did. We hit the care coordination, and everyone there was able to hit our 2 measures, and will receive a net benefit after IGT of a little over $800,000. So we got the max amount that we could with the 2 measures. So good for that. Good job, everybody. And that's really all that's going on there. March, we had a big cash month that we haven't seen before. We can talk about that in rev cycle real quick. So that's it for the cash flow for now.
Do I have a motion to accept the cash flow report? Thank you. A second?
Second.
Thank you. All in favor, Rich?
Aye.
Shelley?
Aye.
Sherry?
Aye.
Ken?
Right?
And I'll vote aye.
So the item 7.3. Okay, so there we go. You know right where to go. So if we look at, well, a couple things. You look at the March column, which is right under the perf of performance. Second line down, total cash collected, $1.59 million. That's easily our highest collection month. A lot of it was driven by the swing bed stay, but it was also, there was more to it than that. We had a really wonderful partnership came through again and settled about $200,000 worth of our clinic claims, paid us $70+ thousand, just boom. And that's twofold. One, it gives us that money, but then it's also gonna get considered when we look at our rate range, and not, the rate range doesn't have the clinic in it. Maybe it does do that, but we can also bill some of those out for the wraparound payment from Medi-Cal. So all good news there. Okay. Going down, so total AR, we've been just hovering, and it was growing. The big growth in December, January, February was that we were hanging on that swing bed claim. But we went down to 93.9 days overall. As you can see there on that line, it was a decrease of 761,000 in AR. Fabulous.
That's great.
Next line down, total insurance, and I tried to talk about this, you know, so that we don't lose sight of the work that's being done, is that we went down to 60 days for, this is actually all third party. It says insurance, but all third party. Target of 45, that we're at now. We went down, that was where the bulk of the payment, the decrease came from, in total AR. But we're getting down towards 45. If we consider the stuff that R1 is reassigned to us, that number comes down even more. It's what they call client assist. It's down at the bottom, but they'll go. Self-pay days, I know, I mean, they went down, right? And the good thing about it is that we saw, and if Ethan, if you could zoom to slide 21 real fast. Sure. I think it's slide 1. It might be the one after. Okay, so scroll down so we can see the payment things. Okay, so if you go out to, so self-pay is 1, 2, 3, 4 from the bottom. That's the amount we receive from patient responsibility payments. So At the time the payment was made, it was classified as a self-pay. Self-pay could be uninsured, which we have very little of, which is wonderful. But it also could be patient responsibility after primary or secondary care. So if you go out to December of '24, we started running out of steam from those initial statements going out. We did a hold on some statements, then we really started going back in January. The collections went up to 21,000. Then they went up to, this is just on the hospital side, the clinic's obviously much smaller. Then it went up to 52,000 in February and almost 69,000 in March. And yes, the AR is a lot, and yes, it's really messing up our AR days number. But that really is back to the issue of we don't have a pipeline, if you will, to send these accounts on through the whole collection process and then in turn off to bad debt as needed. And then they come off our books and all that kind of stuff. So, but this means that the statements that we're sending out right now, we're getting good payments on, which means the patients are understanding them and they're accepting them and they're paying them. So that's the silver lining in the otherwise not good numbers, and we just continue to work forward. Now that we think we have statement issues resolved, now the focus for us is to build that pipeline to get us to the 180 days. We can't turn an account to collection prior to 180 days per California. So that's where we need to get to get these numbers down. It doesn't matter really because we put a reserve on this AR, so it's basically we've deemed it highly uncollectible. So when we write it off, there's gonna be very little impact to our financial statements because it's already been reserved through the bad debt allowance. So that's just a positive. Ethan, can you go back to, I think it was slide 3?
Absolutely.
So if you could just slightly scroll down, yeah, so we can see the rest of it. So, the 13 and, okay. Because the denial rate went down on the hospital side, but went up on the clinic side. The other piece is up there, the total CCR, that's a clean claims, rate. And we had a couple things that we're having some challenges with. I don't know, it's in a specific slide after the little speedometer where it tells you how we're doing to target. Getting taxonomy codes onto our claims for partnership. This is a matter of coordinating this with Cerner so that we get that information into the system, so the taxonomy codes are there. Should have been there all along, but no, that's another story. And then the denial rates, I thought that this is again as the combined, so we are having some issues with denials. But they'll continue to work them if they can.
What's
So
our goal for insurance AR greater than 90 days? What's our target?
it says 25 there, it probably should be a little lower than that.
Column header up there.
Yeah, so the target is the 25 right next to the red dot. We've talked to R1 about this, that we think that this should be even as low as 15 because we have such a high Medicare population and that there's no way that Medicare should be aging out. Insurance is gonna pay or deny within 120 to 180 days, so it shouldn't be there. I think what we're seeing is that there's some, as we call it, dead AR on the books, stuff that we can no longer bill to a third party because timely filing requirements or whatever it may be. So we could see some of that coming off the books. Again, we've reserved for it. It's lost money, but no.
And Shelley, this is reflected in the legislation that's being passed, because they see this too.
Yeah. Well, I'm looking at that 13.1% initial denial rate too.
Let's go, since we're there, let's go to, cause I thought the hospital was 9 and maybe, So, oh, silly me. I was looking at February. So yeah, both the hospital and the clinic were right around 13. Bundling, ooh, off. So,
Cody?
no, did we get an authorization for a service that was needed? And I think that this is something that we're really working on, that, we're getting a little bit further along with fixing all the build issues and the, claim issues as far as just get him to go out. Fine, is that now we're starting to actually do the CQI process of revenue cycle, and Cerner uses the term work items. So when something happens, we put it into a work item and someone's supposed to work that. And so in a lot of the cases, when we get a work item, it could be a registration denial, a registration error or something like that. If we go back and fix it, then we become subject to whether or not we get it done timely or wherever it happens. So this is kind of a great, kind of a monumental, if you will, not to overstate it or get too, fluffy about it, is that this is a big moment when we go from transitioning from trying to fix the Cerner thing to get claims out. We still have workarounds with the Cerner system. But now we can start really doing active revenue cycle management and get everyone engaged in it. And have them work it, and Charlene Almacera is doing a really great job with her team she reports every week about, she takes their work queue and prints it out, and we put the number of items that are the work item, puts the number of items in there, puts a dollar amount with it, and we can see the numbers and the dollars coming down. So this is where we make hay. We just have to be a little more timely, and we understand the constraints we're dealing with, but a little more timely with resolving these things. But that's how we learn.
It's like we're showing some positive movement.
Yes.
So I
Yeah.
think your team is doing a great job.
Yeah, the R1, Sarah Lynn and I have a weekly meeting with our team leader from R1 and her boss. And the client assist had gone down again, and they thought that was just the greatest thing, because you can see that client assist went from 12.2 to 10.9, 10.3 to 9.5. That shows that we're starting to work these things that have been reassigned to us. And that's a great, the numbers are all going in the right direction, except for the ding dong denial. But I think what we're gonna find is that we work things that we're gonna find that we
Well,
get.
it's to the office, they can't even do 5 days for routine. But how are they gonna, this whole 24, 48, yeah, forget it,
Well, we're somewhat on top of that. Where we get tripped up is on the weekend, because we don't have dedicated
Right.
24/7 case management, but they seem to be, I don't know about that rule, but the payers seem to be good with this, as long as we give them some kind of notification, and that's what we've worked with the registrars. If a VA comes in, send that notification off, if they hit the ER, so. But we keep working on it, and it's all, really is a CQI process, and it's a continuous education, so. So anyway, that's kind of it for R1.
Thank you, Steve.
Questions or?
Yeah, a quick question, Steve.
Sure.
Have enough money in the budget from some of the savings, maybe buy a little pointer or laser?
well, and do the call.
I think
maybe
we
a
should probably have one of those
Brian
every board
question.
meeting, just passed off, so you can.
Yeah.
Otherwise, the eye chart.
Make a note back there. IT budget, laser. Go to the football games and shoot the quarterback.
And I just wanted to mention, Steve, at 5 o'clock, we were going to plan to go back into closed, so, if you wanna highlight
The
anything.
only thing I have to say about the last piece is, the numbers are there, everything's there. Our February draw request, which is, request A, is in with the USDA. We got some feedback from them. we're still kind of handling with them about getting that paid, and we sent 9 in as well, which is the March stuff, so we didn't pay anything in March, we're hoping to pay something in April, that's it.
Thank you, Steve. Appreciate everything
Thank you guys.
very much.
A lot of work.
Okay,
Moving right way.
so we are approaching 5. I wonder, you want to give your report real quick so that we'll go ahead and do number 10? And then, that way you won't have to sit around afterwards. Thank you, Chelsea.
Now you know she wants to do this.
Foundation report. So we touched on, the donation policy in the last one, so I'll skip that for you guys. So golf tournament has been a big to-do. It's, everything's starting to come together, so we're getting everything worked out for that, it's going great, more and more sponsors are coming in, we got another one today, so that's great. SPI did sponsor us for $5,000.
Oh, that's great.
So we did send them a thank you, we've been sending thank yous to everybody that sponsors, Inland has sponsored, Light Care is sponsoring. Care Play, yes, I said that backwards. And yeah, we've got a whole list of sponsors, they're going out online to the public, so. Partnerships, so we're working on partnership levels. The idea of the different partnership levels is, this would be a fee that the business or entity or donor would pay to be a partner of our foundation and our organization. But this partnership level, so at certain levels, so we will invite them to interact with us in whatever events we're doing. So if we're out at the band shell as a partner at this level, come and join us or whatever it may be. So we're working through the logistics of those. Hopefully the next meeting I'll have like a finalized version of the levels to be able to share with you guys. But even something that we're putting on the partnership levels is you are welcome to attend any of our district board meetings, which they're welcome to anyways, but we're so.
Nice to invite them.
All of that stuff, just we're spelling it out so that they can feel more connected with the organization if they do want to partner with us.
I like it.
And that we're working on because PG&E actually wants to partner with us in some way, so we're working on levels and not sure what, type of budget they're gonna have yet for that, but they do want to be a partner with us. Other than that, we are, the contribution form for staff did go out. We are fine tuning that because we did get some feedback of staff going, if I don't want to contribute, how do I get this form to go away in my pay column? So, we're making some tweaks to that and letting staff know that it is entirely optional. And then if they do contribute, we are working with them through the process of thanking them.
Making sure they know it's tax deductible.
Yes, making sure they know that it's tax deductible and all of that. We are planning a foundation open house for June 13th, and we have your senior money at work event. So that is currently June 27th, if you're thinking that one, it'll be in the back parking lot.
I was actually talking these events up, giving that some people the other day, just so you know.
And we have, flyers that, I'm gonna look over again tomorrow, and those should be going out to the public. So, we'll get those out, and then the Via Beam event will also go out to the public. One of the new things that we had talked about is making a community beam. So a community beam will be a beam that we are going to let anybody in our community sign for free. One beam, we're thinking about doing this at our Senior Money at Work event.
I like it.
And basically, this is another way for us to say thank you for passing the bond measure, thank you for participating, with us.
I think that's awesome. I love that.
Sign it as yeah, so it'll be a community beam, and so we think that'll be a really fun.
Community being.
Yes, there's that, and then buy your own beam. So, there are hundreds of beams, so I don't think we're gonna run out of beams anytime soon. I was going through the list, there's a lot. And yeah.
Good thing to check though.
Right, we did check, and a lot of them are very similar in sizes. So it's not gonna be like, oh, this one's massive, and they're all very, very similar. And then we have the impact report that went, so that is being mailed out, so some people might have already received it, some people won't receive it just yet.
We are getting copies of those into our office. When we get our copies, those will go out to all of our board members and our, staff members as well, so that they can see that. And so, yeah, it's just, I don't know how they exactly did the mailers, but they mail them out in sections. Because they're going out. Other than that, we're just, cruising along, doing our communication, we're working on the Q2 mailer, which will be, we'll go back to a letter at the, end of this quarter, and the letter is updated with what levels everybody's in. So it'll say, you have donated this much, you are in this level. Please let us know, if there's, any discrepancies or anything like that. And then also, please let us know if there's a certain way you would like your name recognized when it comes to the bill, because we are starting to log that, because we are starting to get feedback about, oh, I want to be recognized by my middle name, not my first name, or things like that. So we're starting to track all that as well, so that with the donor wall, when that comes.
It'll be what
Yes,
they want.
yes, and it'll be what they wanted. But
I
yeah,
wonder if for future, of the slips, the donation slips, if maybe you might wanna include that
Right.
on there.
yeah, so that's.
If you could read somebody's writing, I guess you can.
Yeah, that's, we should have like a little thing on there for your name and then the name, how you want it recognized, so on the
Okay.
envelope,
They
there
may-
are those.
Got it, okay.
But the writing is so hard
That's
to
what I was
read.
wondering.
In fact, half the time we're calling people, we're like, hey, what do you mean here? So, but it's good anyways, because people enjoy that phone call, because then we say, yeah, we got your check, and thank you and all of that, so. And then the last part, we just attached golf tournament flyers, we attached, Eileen, and we attached the, Senior Money at Work event. But, we are adding stuff to those because we are adding the fee for the sign. So,
Great.
any questions?
A lot going on.
Concerns?
No, I think you're doing great.
Can I sell you a bean?
Anyone have any questions for Chelsea?
Thank you.
Thank you, Chelsea, appreciate it. All right, and so with that, I think we will go ahead and go for the session. So thank you, everybody who's stuck with us. Go ahead and pause the recording. Okay? Thank you. All right, we are out of closed session. Back in open session. There were no reportable actions taken during closed session. So we will go back to item number 8 on our agenda, new critical access hospital skilled nursing facility general update. Donna? Thanks for still being with us.
Okay, Ethan should be right on his way.
I think we're good. Oh, we're restarted.
We did it.
Go ahead, Donna.
Okay, so I provided the report. I had heard reference previously of whether do you want me to go through each line item, or do you want to ask questions? Your call.
Maybe highlight anything that you want to make sure
Yeah.
we are aware of if we didn't catch it.
Yeah.
Okay, sounds good. Let's see. Biggest thing is that, as Sean said, the pad was rechecked on the 7th of April and determined to be have the correct moisture content to be able to proceed. So as you can see out there, the foundations are being excavated, the rebar is being placed, and the first pour for concrete is scheduled for next week. We're working to get the all the verified reports in place for an HCI visit next Tuesday to make that happen, to make that first pour happen. And it's being done in the critical access hospital portion, not the skilled nursing yet, is being poured in 4 different phases, and in parallel the underground utilities within the pad are being the trenches are being excavated and utilities laid for that, so that then we can proceed to slab, subgrade, and ultimately putting the reinforcing for the slab in and pouring for that. We do have, I believe as of last, we have both the increments 1 and 2 permits received as of last board of directors meeting. We are still waiting for increment 3 approval. Where that, as well as a change directive called ACD 3 is also another critical one. So increment 3 permit and ACD 3 are ultra critical. And we're pushing on HCI as best we can for those to make sure that we don't hold up the progress for the underground. I think other than that, I think just that we don't have any contingency usage requests this month. We're getting the change order, the construction change order from contingency usage request 3 is there were some comments on that, very minor comments as far as dollars are concerned, but USDA required them to be changed, and so we're working with Jimmy at Motley Hamlin to get those changed, and we'll get that to them, and anticipate getting the construction component of the next outlay request, at least the change order 1 incorporated into that, but not probably change order 2, that we're still working on getting those changes again from Motley Hamlin. Other than that, I think everything else is either been discussed or I think it's been discussed in other reports.
Hey, I have a little update here for you, Donna. Rich Silva did you see his email?
Yes.
Okay, so we've escalated past Antonio. We're gonna go to Ryan. I'm gonna send my note to Ryan to say, please. So hopefully Inc. 3 will be coming shortly.
Perfect. Sounds good. Yep.
Okay, any questions for Donna?
I have a comment. Donna, I just wanna give you props. Donna's doing such a good job of trying to herd cats. And I'm talking lots and lots of kitties running everywhere. And I think that Rod's doing a good job of herding his subs, but Donna, I wanna give you props because, man, has this been a lot. Just trying to get these things moved through and questioning, being our representative, questioning the contractor, questioning HGA, and so props.
Thank you. I appreciate those kind words.
Getting workers
No,
here? No,
no.
not at all. What
They're,
about housing and all that?
they seem to have it under control.
Okay.
And I can tell you that we had a great conversation with Chrissy and Heath. From, their food truck is gonna be here May 15th, and we've got a location
Oh,
for
wow.
them,
Oh, good.
and it's gonna be servicing the community, but also the construction workers, so
What are
they're.
they gonna do at the old subway bin? Just do the cooking there?
Mhm. So,
Yeah, and I want to dovetail on what he said too, Donna. Thank you also. I want to thank you
Yes.
also because I know that you are doing a lot behind the scenes and a lot more than we even know. And so we really appreciate all of your hard work. on
my
that
biggest
project.
thing is just breaking down the acronyms. Just, what, what does that mean,
Yeah,
Donna?
yeah,
I'll explain it
yeah.
later.
Every industry has their own set of acronyms.
Well, thank you guys. I appreciate that.
Thank you. Any other questions for Donna?
Oh, thank you.
Thank you, Donna. Appreciate your staying on.
Okay, thanks, guys.
Bye.
All right, so that brings us to item number 9, policies and procedures. And I was glad to see that the one that was for telecommuting,
Yeah.
kind of the comments that we had made
Yeah.
were incorporated
Yeah.
into that, and I felt like that turned out really nice. So I don't have any other comments on these. Any board members?
Well, quite a few were being rescinded, but looked like they were
They're being
Lots of-
consolidated.
lots of cleanup.
consolidating, yeah.
Yeah. Okay.
Rescinded because replacement is in,
They're incorporating
No longer
into another.
necessary.
Yeah.
Yeah.
They're
Really,
combining some
Yeah.
too.
not relevant,
Yeah,
because a lot of the stuff is 15 years old.
right.
All right, so I will accept a motion to approve the policies and procedures as presented.
Motion to approve.
Thank you, thank you. All in favor, Shelley?
Aye.
Sherry? Ken?
right?
Rich?
Aye.
And I'll vote aye. That brings us to item number 11, our medical staff report. Do I have a motion to approve hold on, let me find it first. Okay, looks like we have an initial appointment and 2 reappointments. Do I have a motion to approve the credentialing as presented?
I'll make the motion to approve.
Thank you. Do I have a second?
Second.
Thank you. All in favor? Rich?
Aye.
Shelley?
Aye.
Sherry?
Aye.
Ken?
Thanks.
And I'll vote aye. So now that brings us to item number 14, which was board meeting closed session scheduling. And I wanted to talk about whether you guys felt like this worked for our closed session being, well, in theory, it was gonna be separate. Separate from our regular meeting. We don't have to decide today, maybe think about it and let Deborah know your thoughts on it.
I just didn't quite understand the difference between the functional difference, I guess, between
Didn't end up-
starting earlier or, having a special meeting.
Yeah, it didn't end up functioning any different, except for it would probably be close to 7 by now. If we had,
Okay.
as we hadn't done it that way, so.
Well, we could have, just, I mean, I'm just wondering if, as a matter of course, we
We
want
wanna
to start
move our
at
regular meeting earlier.
Yeah,
Oh, well, that's
And do close.
interesting.
and then do board, yeah,
two close with first. Yeah,
We
I
could-
like the idea of being closed first.
earlier.
Well, how about, well, I'll ask Deborah to float out to staff as well as to the board members to see if that would work, if we do that going forward. And if so, then we can take a vote on it at our next,
It
we can
definitely
even vote on our
works for some of the
special
people that we
meeting.
need in, that in close, like legal counsel and stuff like that.
Mhm.
It's-
Then they're not hanging over.
Yeah, starting with close.
Yeah, okay.
We're hanging on
Right.
the whole meeting in charge.
The only negative that I.
What's wrong with scheduling them to come in at 5 o'clock? Like that?
Nothing. Is that the public, if you start at 2 and close, you need to really hold that you're gonna go out and close it.
Right, it's bad.
Because in fairness to the public, if they've dialed in or they're here,
Mhm.
they have a right to expect it to start at 3.
Okay,
But I think we're more likely
But I
to
think
be able
we're-
to finish closed session stuff within an hour than.
Yeah, I do.
okay.
And the worst that can happen is then you just adjourn and carry it over to closed session at the end of the meeting.
Yeah, and you'll have to advise me on exactly the mechanics of that because I've not done that. So if you wouldn't mind, that'd be
No
helpful.
So are we talking about starting earlier
Yeah,
at 2?
yeah.
Yeah.
Do
Yeah,
close
the
first.
reason
Yeah.
we started, the reason we started at 3 o'clock is because Dave Slusher was working and he couldn't be there before 3. It used to start earlier. There's no reason we need to start at 3.
Dave's not here.
Right?
So are we discussing so far our next, I imagine we probably would have to vote on changing our regular meeting schedule at a regular meeting.
Yeah.
I would think. And so for our next regular meeting, we could have this topic on, and are we proposing 2 o'clock or are we proposing a different time?
I propose that it be earlier so that we could end earlier.
Earlier than 2, Rich?
No,
Like one?
no, 2 is reasonable, but we're here too late right now.
Yeah, I agree.
Yeah.
Okay. And that was with us starting at 2:15 though.
Yeah.
But yeah, we had a lot of stuff. Okay. All right, so we will, add that to our next regular meeting. And with that, we'll have our future board meeting agenda topics, which at some point we probably need to move to actual agenda topics, but our next regular board meeting will be Thursday, May 29th at 3 p.m. here in the conference room. Meeting's adjourned.
Okay.
Thank you.
Got it.
Thank you. All right,
Thanks very much. We're almost done.
Yeah.
Summer's almost here.
Yeah, you gotta do a second.